Good morning all. Today we are going to see about mitral stenosis. So mitral stenosis is valvular heart disease caused by narrowing of orifice of mitral valves. In this restriction of the blood flow from the left atrium to left ventricle during the diastole. So here, as we know that mitral valve is present in between the left atrium and the left ventricle. Due to this stenosis, there is the blood flow is restricted during the diastole. So next we are move on the etiology. Due to the rheumatic fever, usually severe mitral stenosis take about 20 to 30 years to develop after the last known bout of the rheumatic fever. Calcium deposit, other causes like congenital defect, chest radiation, autoimmune diseases such as the systemic lupus erythematosus. So pathophysiology including that rheumatic fever produce the widespread manifestations in the heart. It will affect the three layers of the heart. So it's lead to endocarditis, ulceration of the endocardium along the HS valves, leaflet where they normally oppose in systole, and then it leads to the tiny nodules of the fibrin and platelets accumulation and gradually brokers the fusion of the leaflets and commissures. That above the mentioned nodules are called Ashkoff nodules. Gradually the valve cups become more swollen and then cuffed. So we know about that. I think people understand about the pathophysiology. The first, due to the infections, the layer of the heart may become affected, and then it will cause the tiny nodules. That nodules is called Ashkoff nodules. So here later the fibrosis and calcification will be occur in the valves. So the valves leads to become thickened and rigid and immobilized. So calcified and then functional valves are seen. This may cause the mitral valve stenosis. And then pathophysiology, according to the cross-sectional area opening the mitral valve can be classified in 4 types: class 1, class 2, class 3, class 4. So here in class 1, cross-sectional area is 2.5 centimeter. So it's a mild asymptomatic, and second one is the 1.5 to 2 centimeter. It's a moderate symptoms will be can see in this patient. And then in class 3, the cross sectional area is 1 to 1 centimeter square. So it will be severe condition. And then fourth, less than 1 centimeter square. So it will the severe condition. Severity is the patient is having the severe symptoms can this type of class 4. And the next pathophysiology, there's 3 hemodynamic events occur. First one is the increase in the left atrium pressure, and second one is the increase in the pulmonary vascular resistance, and third one is the decrease in cardiac output. These are the 3 hemodynamical events can seen in this mitral stenosis patients. And the next clinical manifestation in that symptoms like dyspnea, patient had difficulty in breathing, pulmonary edema, chronic cough, orthopnea, cough without blood, hemoptysis will be there, and then orthopnea, cough with blood, peripheral edema, arterial embolism, angina pectoris, respiratory infections we can see in this patient. And next physical, when we are doing the physical examination, patient have thin and frail with the muscle wasting, dilated neck veins, rails, increased first heart sound, diastolic murmur and the systolic murmurs we can see in this patient. And then other symptoms like so the investigation: echocardiography, chest radiography, electrocardiogram, increased P wave due to the arterial hypertrophy. And then treatment, so here the medication involved, and we are choosing the anticoagulants, blood thinner to reduce the risk of blood clots, diuretics to reduce the fluid build up through the increased urine outflow. And then here we are using the arrhythmic medications, beta blockers to slow the heart rate, surgical valvotomy, valvoplasty, the mitral valve corrected by balloon. Once the mitral valve surgeon inflates the balloon to correct the valve. And next surgery. So mitral valve replacement, the valve prosthesis is placed. If the valve is so rigid and calcified that correction cannot be occur. Regular follow-up to 1 to 2 year interval because stenosis may recur. Here the patient assessment, we have to do the demographic details, chief complaints like chest pain and discomfort, problem in breathing, cough at night. These are the history we have to collect. And next, pressure illness, like we have to about the history, we have to ask rheumatic fever in childhood, medical history, any recurrent infection, systemic illness, drug history we have to ask, medicines taken by the patient, family history, any family member with this disease, and the socioeconomic status we have to assess. And then during the assessment we have to examine about the dyspnea, whether the patient is having dyspnea or not, and cough present at night, hemoptysis present, class 3-4 condition, the patient may have the hemoptysis. And then objective, we have to examine objective in the sense, these are before, what are the things we saw, that is the subjective, that is verbalized by the patient. In objective data assessment, that is we are assessing from the patient condition. So here cyanosis, peripheral cyanosis, and then peripheral cyanosis we can see. In body build we have to examine edema, and then breathing pattern, whether it is normal or not, examine. And then during the examine we have to assess the BP may become increased, have a high heart rate become increased, respiratory rate become normal, temperature become reduced, and palpitation tenderness over the left side, hypertrophy we can see. Breath sounds absent, low pitch sounds, heart sound abnormal, first sound is large, and heart sound abnormal, first sound, and face. The physiotherapy not done at class 1 and class 2. Therapy is given when the patient is operative condition is there. Pre-operative therapy, relaxation is given, breathing exercise, stretching exercise, and then strengthening exercise help to the peripheral and respiratory function. Thank you.